If you're a nursing student, you know your textbooks are packed with theory. But what happens when that theory gets up and walks onto your unit? That's what we're talking about today. We're going to build your practical playbook for impulse control disorders, moving from just understanding the behavior to knowing exactly what to say and do to make things safe and therapeutic.
Okay, let's put ourselves right there, on the floor. A patient looks you dead in the eye and says this. Just feel that for a second. It feels hostile, right? It feels personal. And it's a direct challenge to the entire safe environment you're trying to build. This isn't something from a movie, this is a real scenario. And how you respond? Well, it's everything.
And there it is, the million-dollar question. See, your gut reaction might be to get defensive or authoritarian, but your nursing response, that's a whole different thing. This is that key moment where you have to shift from just reacting to strategically providing care that's safe, effective, and actually compassionate. So to respond in the right way, you've first got to understand what you're actually seeing. Let's do a quick breakdown of the 3 major impulse control disorders you're going to run into most often in your practice. Let's make this really simple. Think of it kind of like a spectrum of defiance. So on one end, you've got oppositional defiant disorder. That's ODD. This is your constant no, that angry, argumentative mood. Then things can escalate to conduct disorder, or CD. This is where defiance crosses a line into violating other people's rights. We're talking aggression, deceit, even destruction of property. And then you have intermittent explosive disorder, IED, which is a bit different. It's not about being defiant all the time. It's about these sudden volcanic blowups of rage that are completely out of proportion to whatever triggered them. All right, so now that we can tell them apart, let's get into the how. What do you actually do? Your direct clinical response. And it all, and I mean all, starts with a sharp, focused assessment that puts safety before anything else.
So where do you start? It's probably not where you think. It's not with the behavior itself. It's with safety. Before you do anything else, you have to remember this critical link, impulsivity and self-harm. They often go hand in hand. So your number 1, absolute first priority is assessing for suicide risk. Always. And you've got to be systematic about this. First, ask about any past suicide attempts. That's the single biggest predictor of future risk. Then you need to evaluate if they have a plan right now. How specific is it? How deadly are the means they're thinking of? And do they have access to them? Next, you've got to probe for those feelings of hopelessness. And finally, you always have to screen for recent drug and alcohol use. It can just plummet their inhibitions and skyrocket that impulsivity. Okay, once you've completed that safety assessment, we can shift our focus to your most powerful tools. Direct intervention and, maybe the most important thing of all, therapeutic communication. How you say something is often way more important than what you actually say. Now, here's a key concept I really want you to master. It's called expressed emotion. All it really means is the emotional tone and content of how you talk. And the research is crystal clear on this. When staff use strongly expressed emotion, criticism, obvious annoyance, that authoritarian tone, it is a major trigger for aggressive responses from these patients. I mean, just look at the difference here. On the left, you have high expressed emotion. The best way to think about this is like you're throwing gasoline on a fire. If you say, you need to stop that right now, you're just inviting a power struggle. But on the right, you have low expressed emotion. This is your fire extinguisher. It's a calm, totally neutral tone. You just state the limit, matter-of-factly, without using personal words like I or you. Believe me, this isn't just a communication trick. It's a violence prevention tool. So what does this low expressed emotion look like in real life? Well, here are 4 go-to tools for your clinical toolkit. First, limit setting. This means clear, calm, and totally consistent boundaries. Second, redirection, just shifting their focus to a more productive activity. Third is planned ignoring. Now, this is for certain attention-seeking behaviors, and sometimes taking away your reaction is the most powerful thing you can do. And finally, behavioral contracts. These are great because you create an agreement together, which really empowers the patient by making the expectations and consequences super clear for everybody. Okay, we've got the tools, but honestly, the tools are pretty useless without the right mindset. And this is probably the most important shift you're going to make as a nurse. It's all about moving past the techniques to really understand the why behind the behavior. And this quote just says it all. This is the absolute core of trauma-informed care. Look, these aren't just bad kids or difficult adults. So often, these behaviors grow out of chaotic, punitive home environments or from rejection, abuse, all kinds of adverse childhood experiences. When you can shift your own internal question from, "What's wrong with you?" to "What happened to you?" it changes everything. That's the real foundation of a therapeutic relationship.
All right, so we've covered the what, the how, and the why. We've decoded the disorders, we've walked through our assessment and intervention playbook, and we've talked about that crucial trauma-informed mindset. So now, let's put it all together. So, meet Jacob. He's 14, and he has a diagnosis of conduct disorder. The scene is this. He's in the day room, and he's escalating. Fast. He's threatening to throw a chair. He's threatening to hurt the other patient. You can see his fists are clenched. He's pacing, and the tension in that room is just going through the roof. And you are his nurse. So now, it's your turn. You're in that room with Jacob. What are your first 3 moves? Really think about it, right now. 1, how do you make sure everyone in that room is immediately safe? 2, what are the very first words that are going to come out of your mouth using that low expressed emotion approach? And 3, what's the specific, clear limit that you're going to set? Go ahead, pause, and think it through, because this is that moment where the textbook closes and your real practice as a nurse truly begins.